All right, so now we're moving on into the respiratory section of CK. And one of the nice things here is that literally everything here is all straight from step one. And majority of it is all also just checked the same way. It's either going to be like a chest x-ray, or you're going to have to do a respirotomy, with the spirometry test. Majority of this at the beginning is all this typical obstructive lung diseases. Then you have your restrictive lung diseases, and there's a bunch of restrictive lung diseases. There's only a couple, four really, obstructive lung diseases. We're going to look at all of them. And then you have your acute respiratory failure, which also includes ARDS, acute respiratory distress syndrome. And we're going to look at a lot of VQ mismatch stuff. Pulmonary vascular disease, mainly being the pulmonary hypertension, which goes back to cardiology with cor pulmonale and right heart failure. Pulmonary thromboembolisms, we looked at a lot of it when we looked at the topics of hemonc, so a lot of it is from there. Okay. And then lung cancer, same exact stuff from step one, whether it's central or peripheral, to help you figure out what kind of lung cancer it might be. And then of course the connections all the way back to endocrine, right? So respiratory has connections everywhere, which not only doesn't make respiratory a very high yield topic, but it also makes respiratory a very difficult topic, because questions can start anywhere and then loop back to another topic, right? So there will be questions about lung cancer that may have nothing to do with lung cancer when the question is mentioned, right? So it might be a patient coming in with hypercalcemia, and then you find out it's due to PTH related peptide, and you relate that to lung cancer. So that kind of stuff, as well as, of course, the connections with Lambert-Eaton. That's another thing you'll see. Pleural disease, that gets a little difficult here. You're gonna have to worry about whether it's what kind of effusion it is, right? What kind of effusion you're seeing, and we'll look at that when we get to that point as well. And then you top it off with pulmonary sleep disorders, which we just looked at when we were wrapping up psychiatry as well, right? So one of the last few things we literally just finished off with were sleep related disorders. Let's see right here, right? For sleep apnea related stuff, and of course people who have obstructive sleep apnea can actually develop major depression. There was also a question on UWorld, very interesting, where they started off the question with the patient coming in with extremely weird symptoms that, as you kept reading, you quickly realize it's multiple sclerosis. They even confirm it's multiple sclerosis when they do the MRI of the patient, and they tell you there's plaques all over the place. So you figured out that her symptoms and her plaques in that female patient in that question were disseminated in space and time. So then they're like, what is this patient at most likely risk of developing? And it was a psych question, because the answer choices were all psych disorders like generalized anxiety, adjustment disorder, MDD. A lot of space for confusion there, right? What a weird connection to make. Then they teach you in that UWorld questions explanation that 2/3, which is a huge 2/3 of the people who get MS end up developing major depression, MDD. So that was actually the answer that I believe only 50% of people in that question actually answered correctly, right? So that kind of connection is something that, of course, step one and step two both love, right? So you'll see the same thing here as well. A patient can we've actually done that practice question in one of our videos in CK right here in psych chapter, where a patient had depressive symptoms, right? All depression symptoms, anhedonia, lack of sleep, blah blah blah, all the typical things, the CG cap stuff. And then they're like, what is the most likely diagnosis? And remember, with psych diagnoses, you can only diagnose something in psych as a specific diagnosis if it doesn't better fit something else. And one of the most notorious issues in psych were that people can have psych disorders that are secondary to something else. Either it was a drug intoxication, or secondary to some medication they're taking, or, as in that case, it was secondary to his obstructive sleep apnea, right? So these things come back and connect to each other. And of course, as you've all probably already seen, USMLE loves questions about connecting things rather than questions that are directly about, isolated situations. That was mostly a step one thing. So we can start off now right away with obstructive lung diseases, which if you go back to step one as well, we can look at just a quick summary of what they described it all as. So of course you have to know these things really well, and if you are not very confident with these graphs, if you don't truly understand how to read them, I will break it down. We'll go into that as well. Right, there's many variations of it. So again, your step 1 and CK can toss any variation of the graph at you, because the point is not to memorize an image and associate it with something, although of course that's one way of approaching it and it helps you. If you can memorize it and associate each image with something, then that's, of course, if you can do it, it's a great way to tackle that. But that's not the real goal. That's not the real goal. It's a graph, and I'm a math guy, so I can't really say memorize it. It's something you should be able to read, and I'm going to help you with that as well. Now, for the obstructive lung diseases in step 1, they had chronic bronchitis, emphysema, asthma, and then bronchiectasis. And there was a lot of pathophysiology, the pathogenesis of asthma, the pathogenesis of COPD, and what happens. And then, of course, they would mix in the physio of all your different lung volumes and how they're changing, right? And being that this is an obstructive lung disease, there were specific changes that would take place, right? So in step 1, the first thing, step 2, the first thing we're looking at, asthma, characterized by, so obstructive lung diseases in general, OLDs, are characterized by airway narrowing or collapse that causes impaired expiration. When you have airway narrowing, that's when you hear wheezing. That's a lot of wheezing that's going to occur on chest auscultation. They have a table that illustrates the role of lung volume measurements in the diagnosis of lung disease, and a bunch of other tables to contrast obstructive and restrictive lung diseases, which is not supposed to be anything challenging. It's supposed to be super obvious if somebody has an obstructive lung disease or is it a restrictive lung disease, because there's really no similarity between the two other than the fact that they're both lung diseases. Asthma is your first obstructive lung disease, extremely common, and so many different ways to ask you questions on it. Reversible airway obstruction secondary to bronchial hyperreactivity, airway inflammation, and mucus plugging, as well as smooth muscle hypertrophy. Most often diagnosed in childhood or early adulthood, but can present at any point in life. Usually presents with a dry cough, episodic wheezing, dyspnea, and or chest tightness, often worsening at night or in the early morning. Physical exam will show you wheezing, as it will show you wheezing in any obstructive lung disease. Prolonged expiration, which is a key part of obstructive lung disease because the obstruction is in getting air out. Increased accessory muscle use, tachypnea, tachycardia, hyperresonance. So we also have to revise our auscultation sounds that you hear, whether it's hyperresonance or not, and so on. And possible pulsus paradoxus. Pulsus paradoxus was a step 1 favorite, where they would tell you a description of pulsus paradoxus and then ask you what could be one of the major issues with the patient. Now remember what pulsus paradoxus was. Remember that when you breathe in, blood is supposed to come back to your heart, right? In these patients, oftentimes, well, in this specific patient in asthma, breathing in isn't so easy, right? That's exactly what happens in asthma. They can't really breathe in, right? So when they do finally breathe in, they're supposed to, right? When you breathe in, blood pressure shouldn't really fall that much because you should have a lot of blood coming back to the heart. But in these patients, not much blood will come back to the heart, and they're going to have a drop in diastolic blood pressure every time they breathe in, and that drop is the paradoxical drop. So that's why it's called pulsus paradoxus, and we're gonna see more of that as we go on. This also occurs in a couple other issues, and we're gonna need to know what all of them are. Late signs: decreased breath sounds, cyanosis, decreased oxygen saturation, and hypercapnia. Now, hypercapnia is also a feature of all the obstructive lung diseases, because remember, the obstruction isn't getting air out, so the air that's supposed to come out is mostly CO2, so you retain a lot of CO2. And then the asthma issue is breathing in, right? So now think about it, you have obstructive lung disease, you can't breathe out easily, and you can't breathe in because you have asthma, right? So both issues are coming in to play. So since they can't breathe in, they don't have many breath sounds, they get cyanotic, and they don't have much oxygen. Very straightforward, right? You got to make it as logical as possible. A certain subset of asthma is aspirin exacerbated respiratory disease. This is also called NERD, N-E-R-D, for NSAID exacerbated respiratory disease. It doesn't just have to be aspirin, although aspirin is the most notoriously known because remember at some point in life everyone has to start taking aspirin. It's one of the most consumed medications in the world. You get a Samter's triad of asthma, chronic rhinosinusitis, and the most specific giveaway, nasal polyps. You know, for everyone watching the video, it's probably never been a thing to ever really get nasal polyps, right? And if anyone watching this video has ever had nasal polyps, then they probably have NSAID exacerbated respiratory disease, where if they were to take NSAIDs, they would get an asthma attack. All right, this is different. This is not something you really have to treat similar to asthma. It's not real asthma, right? So clearly we know in medicine that if something exacerbates a problem, the treatment is to get rid of that something. So this patient should never take aspirin, right? They should never take NSAIDs, in general. So this is a pseudo allergic reaction. It's not really an allergic reaction. There's no IgE in here, but it'll look like an allergic response to NSAIDs. And just because of terminology and to make things easier, we often do tell patients in the real world, oh, you're allergic to NSAIDs, so they understand that they should never take it, right? We don't need to break down the entire education aspect for them. Best initial test, as I said, spirometry, pulmonary function test. You see how quickly they can breathe out, how their breathing in is going, right? Obstructive pattern is going to be seen, and it's going to be reversible with the use of short-acting beta agonists. Right, so short-acting beta agonist is always going to be called a SABA from here onwards. And notoriously, you're going to see FEV1 to FVC ratio under 70%. This means that the numerator, right, is becoming smaller, right? Because this 70% is like 7 over 10, right? That's 70%. So expiration in 1 second, FEV1, how much air can you breathe out in 1 second, is going to be low, which is the definition of an obstructive lung disease because they cannot breathe out. Normal or low functional vital capacity. Usually it'll be normal here in asthma because the lungs are perfectly fine. The problem isn't with the lungs. The problem is more so in the tracheal area and the bronchioles. High residual volume, which is again key in all obstructive lung diseases because again air is trapped inside. And high total lung capacity because again air is trapped inside. Very straightforward. And very key thing, normal DLCO. So this is going to get tested in questions with, you know, they'll list these things out for you: FEV1, FVC, RV, TLC, and then DLCO, and it'll have up and down arrows. And then first you'll have to figure out the patient has asthma. Then second, you'll have to get the answer correct by figuring out these up and down arrows, and you get it right. Now, if you fucked up and didn't realize it's asthma, maybe you thought it's COPD, then you may pick some of the wrong answer choices because they do have somewhat differing. Actually, none of them have the same exact up and down arrows, and most of them are different because of DLCO. So DLCO is the diffusing capacity of the lung for carbon monoxide. This is basically telling you that if it's low, it's telling you that oxygen diffusion is not happening very well in the lung, right? Oxygen diffusion and carbon monoxide diffusion are pretty much the same. I mean, if anything, carbon monoxide diffuses more easily, which is why carbon monoxide poisoning is so terrible, because your body and especially your lungs are gonna like the carbon monoxide more. Your hemoglobin is also gonna like the carbon monoxide more than oxygen, and then that causes death. So this is why we check with carbon monoxide, if anything. Not really that you check this per se in the real world, but this is something that'll more be a testable topic. So if DLCO is low, that means that air diffusion is not really happening very well in your lungs. So that means there's a problem at the alveolar level. Increase in FEV1 with the use of albuterol, which of course is diagnostic now, because if giving you albuterol makes your asthma go away, then you must have asthma, right? Or if giving you albuterol makes the symptoms of asthma go away, then now I can say you have asthma for sure, and I know what to give you. Pulmonary function tests are often normal between exacerbations. When they're not having an asthma exacerbation, everything's fine because their lung is fine, everything's okay, right? One of the things that aren't really done in the real world either is a methylcholine challenge test. Methylcholine, remember, it has choline in the name, so it's kind of like acetylcholine and stuff like that. This tests for bronchial hyperresponsiveness. It's useful when pulmonary function tests are normal and asthma is still suspected, right? Because of course, as we just said, pulmonary function tests are going to be normal unless your patient is actively having a asthma exacerbation at the moment you did the pulmonary function test. Considered positive if you see a more than 20% decrease in FEV1. Okay, so coming back to here, let me just go all the way back to pharmacology. Okay, so remember that bronchodilation occurs with sympathetic activity. Sympathetic meaning epinephrine and norepinephrine. This is why when you have a patient who's having difficulty breathing, you can just give them a quick EpiPen stab and they should be okay, right? Because epinephrine will cause dilation using beta-2 receptors and they'll be able to breathe and you'll save a life. Any choline, like the methylcholine that we're using in the test right now, the hyperresponsiveness, this would be parasympathetic. So you don't need to have bronchodilation on a regular time when you're sleeping or resting, right? Because you just need to breathe at basic rate. Fight or flight, you need to breathe a lot quicker. So that's why bronchodilation occurs with sympathetic input. Parasympathetic input actually causes bronchoconstriction. Now, when you give somebody methylcholine, of course, any human you give methylcholine to will have bronchoconstriction, but you're looking for excessive bronchoconstriction, hyper-responsiveness, more than 20% decrease. So don't fall for the trick if they give you a question where they gave somebody methylcholine and maybe there was like a 10% reduction in FEV1. That's normal. That's exactly what methylcholine does. But if you have hyper-responsiveness and you get more than 20% decrease in expiration, that's somebody who has asthma. Right, so make sure you understand that aspect. This is, you just lost a fifth of your breathing power just because of a little bit of methylcholine. That's asthma. That's an asthmatic patient right there. You can also do arterial blood gases, right? So this is something that, of course, step 1 and step 2 both love. In my step 1 lectures, I've done the entire breakdown of acid base, how to understand it, how to master it, how to have no difficulty in really evaluating when they give you acid base abnormalities and arterial blood gases at the same time. In these patients, remember, this is asthma, so they can't really breathe in very well, and asthma is a obstructive lung disease, so they can't breathe out very well either. So of course they're going to have hypercapnia, which causes acidemia, right? But theoretically speaking, in this case scenario, you would see somewhat of different things depending on what point the asthma is at. Remember, asthma, although a chronic condition, it occurs in attacks. It's not something you're constantly going through. You're not asthmatic all day, right? It's like it happens and then you're normal for most of the day and then it happens again at different exacerbations. And every time the exacerbation occurs, hopefully the patient had something to get rid of it. So they're not actually chronically actively asthmatic. They're asthmatic, but they're not actively asthmatic, right? So early exacerbation actually presents with respiratory alkalosis, which is caused by the hyperventilation, right? So when you hyperventilate at any case scenario, you breathe out all your CO2, so you end up becoming alkalotic. But later severe exacerbation with impending respiratory failure causes respiratory muscle fatigue, can't breathe anymore, and then that results in respiratory acidosis caused by the inability to actually breathe, right? So now you're stuck with all your CO2 inside. Normalizing PaCO2, normalizing pH, and reducing PaO2, right? So this actually eventually proceeds on to causing acidosis. So if a person had like 7 back-to-back asthma attacks on the same within like a 12-hour period, they're probably going to be respiratory acidotic patients. All right, so you got to be careful in understanding that. Remember that anyone having an exacerbation right at that moment, recall from anything you have seen, whether it was real life or in a movie, that the person is going to be trying their best to breathe, right? They're going to be trying their best to breathe, but it's not really going to be easy, and it's going to make a weird kind of sound because they're trying to breathe in into really thin, closed down trachea, right? So it's like breathing into a very thin pipe, and of course not enough air is going in, but they're using a lot of muscular effort to try to breathe in. And since they're trying so hard, breathing in isn't going very well, but when they breathe out, they do it pretty well. And at that point, because the ability to breathe out is a little easier for humans than breathing in. Breathing in actually requires a lot of active muscle use. Breathing out just occurs passively for the most part. So in the beginning, from their massive efforts of trying to breathe in, they become alkalotic, all right? Because they're going to be hyperventilating and they're going to lose all the CO2 because, as I said, it's passively easy to lose your CO2. Early exacerbation. Don't mess this up either. That's another question right there. There's like, you can literally have a whole 40 question section easily if it was possible to just have asthma questions. That's how many things you can ask about this. When you do a chest x-ray in these patients, you'll just see the typical things you see in obstructive lung diseases. a normal appearance with possible hyperinflation and flattening of the diaphragm if the lung is made big because of air trapping. Okay. How do you treat this? In general, there's a lot of ways to treat this, but in general, you tell the patients to avoid any triggers that have led to them having asthma attacks. And asthma medication and management guidelines are given in a table we're going to look at. Basically, though, with acute exacerbation, if the patient is in the clinic, or in the hospital, you give them oxygen, of course, make sure they can breathe. Give them a short-acting beta agonist. Albuterol is first line. Systemic glucocorticoids to stop any inflammatory responses they may be having, and then short-acting beta agonist and ipratropium as well as magnesium can be used in severe exacerbations. Never use ipratropium alone. Okay, that's a wrong answer choice, right? Ipratropium had the mnemonic "I pray that Theo can breathe again," right? Because Theo was theotropium. There's another medication, and Theo is Spanish for uncle. So ipratropium and theotropium are both for asthma exacerbations, but you don't use them alone. You have to use it with something else. So clearly they've done a good job making sure they spent at least one line explaining, well, not really explaining, just telling you to never do it. Consider intubation in severe cases, although it's rarely ever necessary. Cyanosis, inability to maintain respiratory effort, and altered mental status are reasons you would consider intubation, because that's pretty red flag stuff right there, and the patient may die. Or you could also do intubation in acutely ill patients with a PaCO2 that's way too high, so they're obviously going to have too much acidemia and not enough oxygen, right? Here's a whole list of these medications and stuff, some more information. We're going to look at all of that, but one of the most important things when it comes to asthma is maintenance therapy, right? You got the patient in the clinic, you took care of them in the hospital, you did whatever you had to do, and you got them normalized, but now you have to make sure they're not back again tomorrow and that they can take care of themselves on their own. So maintenance therapy is determined by the classification of asthma severity. Step 1, inhaled SABA as needed for symptom control is first line. As we said, albuterol, right? We all know this. Step 2, add daily medication for long-term control, like low-dose inhaled corticosteroids are preferred. Alternatives include cromolyn, leukotriene receptor antagonists, or theophylline. Continue albuterol as necessary, right? PRN. So adding a daily medication is also something you would do if somehow, for some reason, albuterol is not working out. Remember, this is your workflow. This is how you do your job. So when your patient was given albuterol and then they came back because they're still having exacerbations, the next thing you do, maybe you add cromolyn sodium, maybe you'll add one of the leukotrienes or leukotriene receptor antagonists, or you're going to add the theophylline, right? So this was also part of I Pray That Theo Can Breathe Again, right? Because you have Theo here as well. These are all medications for asthma stuff. Now, if they're still having some issues, then they might come back again. At this point, you can add a long-acting beta agonist, such as salmeterol, right? So you're going to see albuterol and salmeterol both as answer choices. You have to understand what step you're up to in your workflow to pick one over the other. You can also add low-dose ICS, right? That's your the corticosteroid, or high dose of ICS to medium dose, right? Just raising doses at this point. Continue the albuterol, right? So now you have basically the person having albuterol and the salmeterol, as well as like whatever you chose here in step 2. Now, if they still have problems, you increase the dose even more, right? Medium dose ICS plus the long-acting beta agonist, continue albuterol. So basically from step 3 to step 4, there's no real big difference. In step 5 is still pretty much the same. You're making it maximum doses the corticosteroid. And remember, it's an inhaled corticosteroid, so this causes oral thrush. They have to use a spacer, something called a spacer, rather than inhaling it right there. So the key fact on the right side is telling you corticosteroids inhaled in a rush can lead to thrush. But if you use a spacer, it helps for whatever reason. So that's something you have to keep in mind. It might be an answer choice to use spacer. And at this point, where all this effort has not really been enough, you can also consider adding in some more strong medications, because at this point you're wondering, how the fuck is this not helping yet, right? So there must be something else that's bothering them. So you add omalizumab, which is a monoclonal antibody against IgE, because maybe there's some aspect of their asthma that's got an allergic component to it. Or mepolizumab, which is anti-interleukin 5. Remember interleukin 5 from your hot T-bone steak, mnemonic 5 was for the IgE. Continue again albuterol. you never stop the albuterol. They're making sure they kept rewriting it, right? Continue albuterol. In the very, very end, if all this shit is still not working, this is all you can do. This is all you can do. High dose inhaled corticosteroid, long acting beta agonist, oral corticosteroid as well. So now you're also adding prednisone, as well as continuing albuterol, and then some of these other medications you added in between. They're going to be taking everything because they have the worst level of asthma possible. You get tested on this, and we have a practice question we're going to look at regarding this stuff, which is going to come from here, right? Same step stuff you're seeing. Generally speaking, though, asthma itself can get very complicated. So you have to make sure you understand the full breakdown of how asthma really works. So here in step 1, they just told you, findings: cough, wheezing, tachypnea, dyspnea, hypoxemia, some reduced inspiratory to expiratory ratio, pulsus paradoxus, mucus plugging, and these are all things that you may see. Triggers include viral upper respiratory infections, allergens, even stress. Okay. Diagnosis is supported by spirometry and the methylcholine challenge test, as we saw. Patients have hyperresponsive bronchi, leading to reversible bronchoconstriction. There's smooth muscle hypertrophy and hyperplasia. You may see some Kirschmann spirals, which are shed epithelium that form whorled mucus plugs, right? So you're making your own mucus plugs. Those are the Kirschmann spirals. And charcoal-laden crystals, which are eosinophilic hexagonal double-pointed crystals formed from breakdowns of eosinophils related to IgE. But DLCO should be normal, not low. The point is, it should not be low. This is a type 1 hypersensitivity reaction. Keep that in mind as well. You might have a question where it's asthma, but you have to pick the answer choice: type 1 hypersensitivity or type 2, type 3, type 4, like that. So of course type 1 is one thing, an antigen, nothing else, right? Type 2 is antigen and antibody, two things. So this is clearly just due to some kind of allergen, so you pick type 1. Aspirin-induced asthma is a combination of COX inhibition, chronic sinusitis with nasal polyps, and asthma symptoms, which we saw. Great. So now you have a bunch of things that we're going to be needing to know. Let's skip over to right here, pathogenesis of asthma, right? So initial exposure causes asthma sensitization, where some allergen was able to reach a dendritic cell, which is an antigen presenting cell. This dendritic cell then presented that allergen to Th2 cells, and the Th2 cell is going to go do its job with interleukin 5 and interleukin 4 secretion, as well as interleukin 13 secretion, to turn these guys on, right? So you have mast cells now that are primed. Mast cell priming is often an answer choice. These mast cells are ready. Next time this allergen shows up, you're going to fight back, but you didn't need to, right? So that's why asthma is a problem. You're going to fight back to some allergen you really didn't need to fight back with. And eosinophils are all over the place too now. So now you can see with repeat exposure, when that same allergen showed up again, in the immediate phase, the allergen is going to get recognized by mast cells, and you're going to get mast cell degranulation, which of course releases histamine and leukotrienes, causing bronchoconstriction. You also get histamine and leukotrienes causing vasodilation, right? And the vasodilation allows the spaces in between the capillary cells to get a little bigger, so eosinophils can actually come through and then release major basic protein, and you get a lot of inflammation. And this is the long haul of what happens with asthma. In general, though, there's a lot you can do for it, and that's the treatment stuff we just looked at, right? So let me see, what is this? Subacute and chronic cough. Common etiology is a chronic cough. We're going to look at these later on. Okay, asthma should be suspected in children with multiple episodes of croup and upper respiratory infections associated with dyspnea. Childhood eczema is also associated with asthma. Asthma triggers include allergens, upper respiratory infections, cold air often causes asthma in a lot of people. So winters can be very asthmatic for a lot of people. Exercise, drugs, and even stress. Anything of these types can really cause asthma to kick in. And then we have a bunch of practice questions to look at, so let's get this down. This one here is going to help you learn how to actually identify pulmonary auscultation examination findings. So this one has a 56-year-old woman with a history of asthma, comes to the ED due to shortness of breath. Her asthma was previously well controlled with inhaled albuterol, but she has had increasing dyspnea over the past several weeks. The symptoms became more severe today, and she is coughing up dark colored sputum. Other medical conditions include hypertension and diabetes. She has never smoked. She drinks occasionally. Vitals are looking pretty decent. Pulse ox is 93%. That's not too bad either. She speaks in short sentences and is using accessory muscles of respiration. On physical exam, the trachea is deviated to the right and there is dullness on percussion on the right. Scattered rhonchi are present bilaterally and breath sounds are diminished over the right lower lung. What best explains her physical exam findings? So obviously what happened to her is explained by atelectasis. Her right lung is definitely destroyed, right? And she needs treatment right away. She most likely has asthma exacerbation complicated by mucus plugging and a large volume right-sided atelectasis. Mucus hypersecretion can be dark colored and may result in mucus plug formation in the airways from the Kirschmann spirals we just talked about in step 1 book, resulting in distal air trapping that prevents additional air from entering that portion of the lungs. Now those alveoli in that lung area are going to collapse, which is what atelectasis is. The trapped air molecules eventually diffuse into the blood, creating a vacuum that leads to alveolar collapse. Since a collapsed lung has greater density than an air-filled lung, dullness to percussion is present. The lack of airflow leads to low breath sounds. So basically that portion where because of mucus plugging air diffusion isn't happening very well, those alveoli are all going to collapse. So it's like you have two lungs that are holding your trachea midline. As soon as one lung collapses, the trachea deviates, right? So her trachea deviated to the right, and there's dullness to percussion on the right. So this is not a tension pneumothorax, because remember the mnemonic was you run away from tension. So if her trachea was deviated the opposite way to where the lung has a problem, that would be a tension pneumothorax. Here, the lung that collapsed has such a vacuum on it that it actually pulls the trachea towards the side where the lung collapsed, right? So the physical exam findings they explained are key for atelectasis. Also, given the fact that she has asthma, there was no reason for anyone to think that this would be some kind of pneumothorax. It's not a pneumothorax. This is an atelectasis patient, all right? Now, when it comes to these pulmonary exam findings, the things I've circled are the things that actually give you a diagnosis. Anything else is just either not useful information or normal. So we have breath sounds, tactile fremitus, percussion, and a mediastinal shift. All right. Breath sounds are obvious, right? Breath sounds are always going to be, when you listen, you should hear breathing. When you hear too much breathing, it's consolidation, right? When you don't hear any breathing, that means that that lung area is not really having any air moving around, right? So you don't really hear much air moving around in that part of your lung where you have pleural effusion, a pneumothorax, or atelectasis. Pretty commonsensical, nothing crazy with that, right? So then the only part here that really matters was the increased breath sounds. When you have increased breath sounds somewhere, that's because there's a lobar pneumonia or some other kind of consolidation in that area. But the better way to identify consolidation is tactile fremitus. So tactile fremitus is just knocking on something. And the only time that sound is going to be loud is if you knock on something solid, right? If you're knocking and there's consolidation, right? Consolidation, then that's going to cause increased tactile fremitus. Otherwise, tactile fremitus is always going to be decreased in any of these other things, right? They never really tend to mention tactile fremitus is normal. That's not a statement they'll ever really make because it's useless information. Tactile fremitus is either going to be increased or they probably won't even mention tactile fremitus. But if tactile fremitus is decreased, that means you're knocking on something that is the opposite of solid, such as liquid, pleural effusion, completely just air, or again, mucus, right? These are three things that are, pleural effusion is effusion, it's a liquid, right? Pneumothorax means that that one lung has just completely become full of void air, right? That the lung became tiny and that area where the lung was supposed to be is all full of air, but the air is not inside the lung. So you're knocking on air. That's not going to cause much sound at all. Decreased tactile fremitus. And then atelectasis is our patient right here. They have mucus, so you're knocking on mucus basically. And the lung that's collapsed once again, so no sound, right? Now, percussion is like percussing the strings of a guitar, right? If someone percusses the strings of a guitar, the only reason you hear the sound waves traveling to your ear from that string is because of air, right? If you percuss the strings of a guitar in a vacuum, in like outer space, no one's gonna hear shit. So normally, of course, percussion is supposed to give you some resonance because we always have air in our lungs, right? When there's consolidation, you have something solid in the lung, so there's no air in that one area where there's consolidation, so you hear no percussion sounds at all. And if you have pleural effusions, that's water. You're not going to hear the strings of a guitar making much percussive sounds underwater either, so dullness. And when that area is full of mucus, it's also going to be dullness. The only time it's hyperresonance, much louder percussing sounds than usual, is because there's too much air, right? Pneumothorax is a bunch of air that's outside the lung because the lung collapsed. How do you fix that? You make a hole in the person's chest to let that air out so that the lung can expand again, like a balloon. The last thing here is mediastinal shift. The only one we really care about is the away, right? And it occurs in both from the effusion as well as away from tension pneumothorax. But tension pneumothorax is the one where it's going to be a critical finding. Usually they'll just give you a chest x-ray and you have to identify the trachea is kind of shifted away from the lung that's all black, because it's going to be just air, nothing else, right? Air doesn't show up on the chest x-ray. It's just going to be black. So away from the tension pneumothorax because we go away from tension, right? And our patient is going towards the atelectasis because atelectasis is mucus plugging. Mucus is very powerful. It's sticky. It pulls things towards itself. And of course, in the explanation we just saw, that the mucus plugging creates a vacuum, which also pulls the trachea in this direction, right? Tactile fremitus requires something solid for sound to transmit, such as knocking on a door. So this is high in consolidation. Egophony or egophony, which is basically telling the patient to say A or E or something like that, sounds like A when the patient says E in areas of consolidation. Egophony is also related to consolidation. It's not in the table, but it's another thing you look for. So when the patient is saying A on the stet that you have attached to the part of the lung where they have this consolidation, you're going to hear E, and that's a sound being kind of transmitted in a different way now because of something solid, right? Percussion, as I described with the strings and tactile fremitus, right? So that's your entire lesson on understanding what you're looking for in pulmonary auscultation findings to actually diagnose something correctly, right? Here you have your lung volumes, which of course is just self-explanatory. You want to make sure you understand the general volumes as well as the capacities, which, you know, each capacity is a summary of things. The vital capacity is things you're using for being vital. So vital is breathing in, inspiratory reserve, and breathing out, expiratory reserve. So all of that is part of your vital capacity. Functional residual capacity is residual stuff, everything that resides inside the lung, right? So this is how I memorize this. So things that reside inside the lung are your expiratory reserve volume, air you can breathe out after normally breathing out, right? So normal breathing out is happening in the tidal volume. This is normal breathing in, breathing out, breathing in, breathing at normal levels of it. And then if you try to tap into your inspiratory reserve volume, then you breathe in and you maximally breathe in as much as you can. So that's what your inspiratory reserve volume is about. And then you breathe out and then you maximally breathe out, and that's your expiratory reserve volume. Residual volume is air inside your lungs you can never breathe out. It's in places that you just can't pull it out from. And that's your general summary of your lung volumes and lung capacities. Right, so here you're seeing respiratory failure in asthma, as we discussed, and that's your general first question here, where the question started off with asthma, but it connected it to atelectasis because of mucus plugging. General concepts are being discussed here, and that's what you understand there. Here's another one. Now you have a 3-year-old boy. This is related to foreign body aspiration. 3-year-old boy is brought to the emergency department by his mom due to cough and difficulty breathing. He was playing outside with his older sisters when he started coughing uncontrollably. He has been coughing with audible wheezing for the past 30 minutes. So in any baby that starts doing this, you know, if you imagine holding a 3-year-old child in front of you and they just suddenly started coughing like crazy and have a little bit of wheezing, you imagine it's either an asthma attack for the first time ever, but more likely they inhaled something, they ate something that went into the trachea by mistake. That's more likely for a 3-year-old than randomly having asthma all of a sudden, right? So those are the two possible suspicions you bring up in your mind. He has no chronic medical conditions but has had rhinorrhea for the past few days, which really makes you think, oh, so maybe he had a viral upper respiratory infection and now he's getting asthma exacerbation? Maybe. These are just suspicions you're building up as you're reading the question. Vitals look okay, right? Pulse is fast, blood pressure is low, but it's a 3-year-old, so the vitals are not going to be like a normal adult. Pulse ox is 91% of room air. The right lung has diminished breath sounds and expiratory wheezing, which is a giveaway for what's happening. The left lung is perfectly fine. Supplemental oxygen is applied. Chest X-ray reveals hyperinflation of the right lung and a left mediastinal shift. What is the best next step in this patient's management? Now, I have no idea what these people were really thinking when they said that you should do a chest tube placement, right? So these 30% of people are the people that would have seen this 3-year-old at an airport, and then they would want to be the superhero doctor, and they would put a chest tube into the patient that definitely did not need a chest tube. That sucks, right? That's stupid. The reason they fell for chest tube placement is because they're thinking this is a tension pneumothorax, because they're thinking that the trachea is deviating opposite to the direction where the lung has decreased breath sounds. But they mentioned expiratory wheezing. That means that when the child is breathing out, there's some wheezing occurring. That means that there's something in the canal through where air is supposed to be coming out from. Something's blocking the pathway. You know, we've all seen this in some kind of setting where, let's just look at a car exhaust, for example, right? When you try to accelerate the car, a lot of air comes out of the exhaust. If you block that pathway, the air is still going to come out, but it's going to make a much louder sound because it's trying to squeeze through a smaller lumen, right? That's what's happening. So this expiratory wheezing and diminished breath sound only on one side, and that too on the right lung. Remember the placement of your various bronchi, right? That was a key anatomy topic in GIT. In your right lung, it's much easier for things that get swallowed into the trachea to go into the right lung, right? You can see that it's almost a straight line down. Anything that by mistake got inhaled into the trachea, essentially, food that got inhaled into the trachea rather than being swallowed into the esophagus, can go straight down the trachea and then go into the right lung. And depending on whether the child was standing or laying, it can go in the right upper, right lower, depending on, you know, whatever the anatomy or whatever positioning the child was in. Not really in the left. It's very unlikely to go in the left. It's easier to just go into the right. That's just what happens, especially on a step, right? So those were your dependent positions as we discussed way back in step 1, right? So the right lung is the one where it's much easier for things to go into, as opposed to the left one, which has quite an angle to it. So there were a lot of things in this question that gave it away. The age of the child, the sudden onset, the fact that it's on the right side, the fact that there's wheezing. This was not tension pneumothorax. Tension pneumothorax, why would a 3-year-old have a tension pneumothorax out of nowhere, right? So these 30% of people have a lot to learn there, and that's okay, they're learning. And once you learn it, you never do that shit again, right? His sudden onset respiratory distress and chest x-ray findings are concerning for foreign body aspiration, which is most common in kids 1 to 3 years and usually involves foods or small toys. Like it could be peanuts, or it could be a little building block, it could be anything. Patients typically have acute dyspnea and cough, decreased breath sounds on the affected side, and wheezing due to airway constriction, not asthma, right? So this question is here so that you understand that this is not sudden asthma. Over half of the aspirated foreign bodies lodge into the right mainstem bronchus. Although chest x-ray may be normal, classic findings include hyperinflation distal to the obstruction. You can imagine that this little blockade that's happening in that one lung essentially made that lung into an obstructive lung disease lung. Obstructive lung disease causes hyperinflation because air trapping. So that's why there was hyperinflation. Totally makes sense, right? Distal to the obstruction. And the mediastinal shift away from the affected side, right? Because you run away from tension and tension pneumothorax, but there was no reason to think this boy has a pneumothorax, right? While foreign body aspiration is suspected, immediate rigid bronchoscopy is performed to confirm the diagnosis and remove the aspirated object, and the child's going to be okay. Child most likely won't die, but it's really problematic when the child goes through like this because they start freaking out and all that. Chest tube placement for a tension pneumothorax would make more sense if the chest x-ray showed air outside the pleural line and ipsilateral lung collapse, not hyperinflation. Remember, I just mentioned that in tension pneumothorax, what was happening was that you had a lung that became tiny and a lot of air outside the lung. So it looks like, there's a picture I have for that really nice one. Like that. Right, this is tension pneumothorax. You see how the lung became really tiny, and all of this extra area is air, pressure from air entering the pleural space. It looks like this on a chest x-ray, completely black, because air doesn't show up on a chest x-ray. This is proof that this patient has tension pneumothorax. In fact, you can also see the trachea here deviating away from the black lung, going towards the right, because this patient has a left lung tension pneumothorax, right? That's what that looks like. How do you fix this? You puncture this lung, all this air is going to come out, and then this lung is going to blow it up again like a balloon. Okay, and it'll be functional again as well. They'll be fine. The damage they'll sustain from you puncturing their chest a little bit will save their life, so it's worth it. And it's mostly just going to be a tiny hole aesthetic thing later on, not a big deal. And then we have these things, right? How to understand, how to read these breathing patterns that you're seeing here. And what is this? Okay. Where was I? Okay, so how to read what's happening here. Now, there is something really weird about this graph. I'll be straight up. I don't know why it's drawn this way, but it really didn't need to be drawn this way. The correct way of drawing this, when we look at graphs in general, right, anytime we draw axes, right, we label them X and Y axes, the center here is supposed to be 0, 0, right? But you see how they moved this axis over to the end rather than keeping it at 0? That's a little weird, right? That's a little weird because then it causes the loops to be different as well, and I'm not entirely sure what the point of that is. Okay, but this is what's really happening. So if you look at normal one, the normal one, it starts from here. You're having the top part is expiration and the bottom part is inspiration, which is also, in my opinion, a little weird. I think inspiration should be on the top, breathing in, then breathing out, but whatever. So what you're looking at is a person breathing in and then breathing out. That entire loop is flow velocity. This is a velocity. Remember, look at this. Look at how this is written. Liters per second. Very similar to how you would tell the speed of a car, like meters per hour, right? Or miles per hour, kilometers per hour, stuff like that. So this is liters per second. This is the speed. So when I take one breath, this is showing me taking this entire one breath. What happened here is that when I started breathing, initially, the very first breathing in I do occurs very, very quickly, and then eventually the amount of air I'm still breathing in, but the speed at which I'm breathing in slows down. So it's like getting really fast and slowing down. You start and slow down, start and slow down. So it's like at this part right now, it was at 0 liters per second. It reaches a maximum of a little over maybe 5 liters per second, and then it starts going back, slowing down again. You don't always breathe at the same speed, right? Because if you did always breathe in at one speed, your entire one breath was in one speed, it would be like one real quick breath. But that's not how we breathe. We breathe slow and easy. So we initially breathe quick, and then it's still breathing in, but we slow down near the end. So basically our breathing in has a twofold thing to it, right? In the first half of a second we're breathing in very quickly. The latter half of a second we're breathing in a little slower. Okay, it goes back. Why are we slowing down? Because now we have to breathe out. Breathing out usually occurs faster at a higher rate than breathing in. Why? That's because breathing out is a little more natural. It doesn't really require muscles, and it's also bringing things back to the elastic normal position, right? So breathing out occurs at a much faster speed, almost 8 liters per second, and then it goes back to being 0. You stop breathing out eventually, right? So your speed has to come back to 0. That's what's happening here. This is a really unnecessary, in my opinion, weird ass graph that I don't know the point to, right? Because the speed at which you're breathing in and breathing out at, that's what's being checked. Now this becomes relevant when you look at obstructive and restrictive lung diseases, but did we really need a graph for this? I don't really think so. Okay, so in normal, this is what it all looks like. So you see it's all labeled here, right? This part here from the y-axis is really just your volume of air, if anything. Okay, this is the volume of air. So this area here was air that was always stuck inside your lung but never left, right? Total lung capacity is 6 in a normal individual, and that's what you're seeing here, TLC. And then vital capacity was the air you were using breathing in and breathing out. So that's the entire thing from beginning to end here, right? So our actual amount, although total lung capacity is 6, remember the amount of air you're actually using when you're breathing, which is your vital capacity, is usually about 5. Okay, so vital capacity is usually 5. Always got to keep that in mind, and that's what's being used here. So this is a normal individual. Now look at the obstructive one, where we said that there's air trapping, that there's going to be more air inside the lung, and it's going to be difficult to breathe out. So the amount or the speed at which you breathe out, which is your FEV1, will be lower, right? So you can immediately appreciate that, right? You can see your residual volume, which is being depicted by the pink arrow, increased. Residual volume is more now. You can see that when the person is breathing out, the speed at which they breathe out is super slow, right? It only goes up to 4. It doesn't go to where it's supposed to. We usually breathe out real quick, you know? We always do this, right? Whenever we sigh, it took a little longer for me to breathe in, much quicker to breathe out. That's a normal individual. Breathing out speed is much quicker. This is speed. This is a curve showing you speed. So here in this, what's often referred to as a scoop of ice cream being taken out, right? This is supposed to be that you scooped out ice cream from right here. Someone, I think it's Netters or someone, I'm not sure who. It might have been Pathoma guy that mentioned it, but someone mentions it like that as a memorization technique. Completely unnecessary, right? I hate memorization techniques. Why are you trying to memorize a mathematical thing that you can easily read? Now you know what you're reading, right? You can see that the residual volume is almost 4 when it was supposed to be a little less than 2. You can also see that the speed at which they were supposed to breathe out is significantly slower, right? It doesn't even reach full expiratory velocity. This is why we can check for these patients the FEV1. How much air did they breathe out in 1 second? Not much, okay? And then breathing in is looking pretty normal. The lower curve is looking very normal because it's an obstructive lung disease. The obstruction is in breathing out, okay? And their lung capacity, which is the black total lung capacity, looks about correct, you know, almost 5. Looks about the same length. If I was to grab this line I made, pull it over here, it's only slightly altered, nothing crazy, right? That's generally all you're seeing there. Now, if you look at restrictive lung diseases, a restrictive lung is a lung that doesn't expand, which means now it's hard to breathe in. Can't breathe in, right? Restrictive lung disease, think of pulmonary fibrosis, right? So now if your lung is fibrosed, it's not very elastic, you can't breathe in. So look at these patients. Their lung is so restricted that they don't even have much of a residual volume, very tiny residual volume, right? Because all your lung space is actually being used to try to breathe in. So when they try to breathe in, look at the difference. You can see the outline for the pink one, it's halved. The amount of air they can actually breathe in is halved. And then of course, if you're not breathing in much, you're not breathing out much. Now, although they're not breathing out much, the velocity curve has the same shape as this. So theoretically speaking, breathing out is working fine in them. Breathing out is working brilliantly fine in them. There's no problem for these patients with breathing out. They just don't have much air to breathe out. Right? So this one is often referred to as a witch's hat, right? Where if you, or you can come up with any character really, it doesn't matter who you use, but basically this would be the hat up there, this would be the person's eye, right? And then the mouth, that's what you're seeing here. Right, so that's the person that cannot breathe in. That's a restrictive disease. These 3 graphs are not supposed to be even remotely difficult. There's nothing hard about them at all. It's the understanding that you needed when you're taught about them that you need to understand. It says liters per second. This is a speed. This is a speed. This is also something I taught very well in way in the beginning of respiratory physio. When you look at these weird graphs, understand that, you know, these idiots, they didn't really label the fact that this axis is time, right? This axis is time. They labeled the y-axis, okay, but they didn't label the x-axis. So this is your y-axis, right? The up to down, that's your y-axis. On your y-axis, they've labeled it for, you know, there's 3 different graphs are combining with the same y-axis. Each part is labeled. Up here, the y-axis is showing volume. Here, the y-axis is showing alveolar pressure, the amount of pressure in your alveoli. And here, they're showing you intrapleural pressure, pressure in between the 2 pleura that your lungs have. They're the ones that allow the lung to expand and collapse back to normal again. The x-axis is time. So what you're seeing here is a person that breathes in, which is the left half, and then breathes out. So breathing in, of course, the top graph, this part is the easiest part. You breathe in, your lung volume increases. You breathe out, your lung volume decreases, right? That is the easiest thing to understand. This is what we're looking at on the other graph, right? Right here, we're seeing flow velocity, which is related to alveolar pressure. When you're breathing in, this is divided into two sections. In the beginning, you're breathing in very quickly, then the speed at which you're breathing in slows down. Then you're breathing out. In the beginning, you're breathing out very quickly, then the speed at which you breathe out slows down, right? Alveolar pressure changes based off of inspiration and expiration. So of course, when you breathe in, your alveoli expand, they fill up with air, so alveolar pressure decreases, goes down to -2. When you breathe out, your alveoli start to collapse again. It's like taking a balloon and taking the air out of it. So of course, alveolar pressure increases again, right? Now, if you breathe all your air out for whatever reason, your alveolar pressure is going to get too high and it's going to collapse. It's going to break, right? That's atelectasis, which can occur as in that patient we just did. Last thing down here is the pressure in between your pleura, right? That intrapleural pressure is what they made all these fancy graphs for. These three graphs that I just circled are the same thing, being depicted in three different manners from three different drawings. The point of this intrapleural pressure is that if you don't have pressure in between the pleuras, then there's nothing keeping the lung and chest wall system, aka your net compliance, functional, right? If your net compliance isn't functional, then your lungs will just blow up. It's going to be a balloon that's just going to collapse. It's just going to come and become really tiny. That's kind of what happens in pneumothorax, right? In pneumothorax, you lose that chest wall compliance, and the air is just outside the lung now, right? And the lung becomes really tiny. You have to fix that. So that's all they're showing you here. As you breathe in, your intrapleural pressure decreases, because breathing in is really good, right? Breathing in is healthy for you. So all the pressures decrease when you breathe in, and then when you breathe out, intrapleural pressure starts to increase again. By increasing, the pressure actually helps you breathe. Understand that as well. Because this pressure is increasing, you're preparing for the next thing to come, which is once again breathing in. And by decreasing, this actually helps you prepare for the next thing to come, which is once again breathing out. So this teaches you right here that increasing the pressure, aka positive end expiratory pressure, PEEP, which is what we use therapeutically, increasing the pressure is what's actually going to help you breathe in. And if you don't increase the pressure, then you're just going to be breathing out and you won't be able to breathe in, right? And we're talking about the pressure in the intrapleural space right now. So these are some of the, pathophysiological bullshit that I haven't really seen anyone else teach very well. So, hopefully a lot of this makes a lot more sense now. The last thing to mention here is this term hysteresis. Hysteresis is a vocabulary term. It's not really just related to medicine. It's an English word, which basically tells you that the graph looks different in one direction and different in the other direction. That's all it's telling you. That clearly the inspiration and expiration graph are not the same. That's what's called hysteresis, right? Inspiration has one graph to it, expiration has a different graph to it. In calculus, you learn something called a derivative, which is depicted by this black line. A derivative is just the slope, change in pressure over change in volume, delta x over delta y, that kind of stuff. A derivative is just a slope at a given point. So the points they're using is this point here, and this point here. The derivative is showing you in this specific thing, the black line here is specifically showing you the compliance, right? The change in pressure with the change in volume that is occurring as you're breathing in. The red line is breathing in. So look, in the beginning, when your lung is empty, there's low compliance at low lung volumes, okay? As you breathe in, compliance increases. And when you maximally breathe in, compliance is maximal. Compliance means how willing are you to comply? How willing are you to change? As you're breathing in, your lung is more willing to change, right? Because as more air is coming, your lung expands. This is not going to be true in a person with restrictive lung disease where you have fibrosis of the lung and it doesn't want to expand because it's all fibrosed. It's not very flexible. It's not going to be true in a patient who has alpha-1 antitrypsin deficiency because they have too much elastase activity. They lost all their elastin. So once again, the lung is not willing to expand. It's not very elastic anymore. They lose compliance, and that's what you're seeing in this graph. This graph is showing you normal stuff. So this is this part is the most important part right here, that as they're breathing in, there's actual compliance taking place, allowing them to be able to breathe in, right? And then when they breathe out, look at how quickly it just falls, right? Breathing out is a lot easier, and you don't really necessarily need compliance to breathe out. To breathe out, you just breathe out. That's messed up in obstructive lung diseases where there's something blocking the path to be able to breathe out, right? So that's your, I think in a nutshell, full physiologic understanding of how the lungs work and what all these graphs are about, and what you're really going to have to know and understand when you're given any kind of graphic representation of any of these bullshit things. The last thing left with asthma is an understanding of the various scope of medications. Now, you don't, in step one, you already learned what all the medications did, what their side effects could possibly be, and where you were supposed to apply these medications. It was almost a little fake in step one questions. It wasn't very realistic because it wasn't really a test for clinical knowledge. It was more of a test of, do you know what this medication is and do you know what that medication is? Here though, it's a lot more realistic. Take a look at this question. This question is related to what we just discussed here with the maintenance therapy and the various steps for your work procedure of how you're going to do your job. A 34-year-old man comes to the office for a routine health maintenance exam. She has a 5-year history of bronchial asthma, for which he uses an albuterol inhaler during the day, an average of twice a week. In addition, his asthma symptoms wake him from sleep about 3 to 4 times a month. He is allergic to dust mites and ragweed, but he has no other medical issues and takes no other meds. He does not smoke, drink, or use drugs. His family history is significant for asthma in his grandpa. Vitals are normal. Lung auscultation indicates normal breath sounds without wheezing. Heart sounds are normal. What is the most appropriate next step in management? Now, it's good that his normal breath sounds are showing up without wheezing, because that means that he actually does have asthma, right? In asthma, anytime you check the patient when they're not having an asthma exacerbation, everything should be normal. It's only when they're having an exacerbation that you should hear wheezing, that you're going to hear anything else that's messed up for whatever reason, right? Because they're actually having an active asthma attack. Being a passive asthmatic patient is different. A passive asthmatic patient who's not having an active asthma attack should have completely normal lung auscultation. So in this guy, what can we do more, right? In this 34-year-old man who 5-year history of asthma, he already does the albuterol. You know, he's been using it twice a week, but now his asthma is getting really bad. It's bothering his sleep. He's also got allergies. This part was really just mentioned to throw you off because there was an answer choice that was against IgE stuff, but you didn't need to pick that because remember, no matter what, you have to follow protocol. You have to follow your workflow, right? So if we're already on this step one right now, where he's already, you know, taking albuterol, the next step is to add an inhaled corticosteroid. Step 2, add a low dose ICS, inhaled corticosteroid. Your workflow is laid out for you. You don't change this shit up because of anything else in the question. Add inhaled corticosteroid was the easy, simple, straightforward next answer, just based off of a work portfolio you would, your work flow that you would have. In this patient with a history of intermittent asthma, managed as needed with a short-acting beta agonist albuterol, the need to initiate controller med therapy is evaluated by categorizing symptoms into one of 4 levels of asthma severity, as in this table below. This patient has been requiring his albuterol inhaler 2 days a week, which suggests good control because 2 days a week is pretty decent. However, he has been having 3 to 4 nighttime awakenings per month, which indicate he is undertreated with an as-needed short-acting beta agonist alone. Based on his current level of symptoms, he now meets criteria for mild persistent asthma and warrants step up in therapy with the addition of a low-dose inhaled corticosteroid. Once patients begin asthma controller therapy, they are evaluated based on symptomatic assessment of asthma control. Patients whose condition remains well controlled on the same therapy for 3 months should be considered for a step down in medication management. So this is the only additional information that they didn't mention in the book. So let's say, you know, this patient is here right now. They're presenting unhappy because of nighttime awakenings. We're going to add them into this category now by giving them the inhaled corticosteroid. 3 months pass by and they're doing better and they're okay. You bring them back down. Take the low dose inhaled corticosteroid away. They may not need it anymore, right? And then wait and watch and keep seeing how they do. That's what they're explaining here. That could also be an answer choice you may have to pick. Okay. In patients with very, very poorly controlled symptoms, medication therapy should be increased by 1 or 2 steps, and a short course of oral prednisone should be considered. right? So of course, if you go just one more above, then the next step to here would be to now add a long-acting beta agonist. If you go another step, you're making the dose of the inhaled corticosteroid stronger. And if you go one more step, you actually consider some of these other medications like omalizumab if they have allergies, or just make it a high dose inhaled corticosteroid. So from steps 3 to 5, all you're doing is systematically increasing the strength of that corticosteroid. The very last thing to do is actually add prednisone, oral corticosteroid. Not that complicated in my opinion. Of course, the first time you look at it, you learn it, and then after time, it should stick to you pretty well. But the theory is pretty straightforward. Everyone's taking albuterol for their asthma. They're taking some dosage of inhaled corticosteroid depending on how bad they're doing, and a long-acting beta agonist as well for better control. The short-acting one is for acute exacerbations. The long-acting one is for long-term control, right? So they don't get another attack all day, and they don't get one at night either. And then the corticosteroids are to decrease inflammation, because remember, we saw the pathogenesis of asthma. We saw that there was inflammation in the later half of asthma exacerbations. Okay, and that's basically it. The rest of that is just broken down in a similar manner here, but this practice question does the job. There's a URL question to tell you what to do as well, which step to go to, but it's in order. You almost never really skip a step. Okay, this patient's allergy thing they mentioned, he's allergic to dust mites and ragweed, but has no other medical issues and takes no other meds. See, if his issue was actually related to those dust mites and ragweed, then they would tell you, right? He is allergic to dust mites and ragweed, but does he have dust mites or ragweed at home? And has his asthma actually been related to dust mites and ragweed? Not at all. They told you that he has nighttime awakenings, which means that he's suddenly having asthma attacks in the middle of the night. There's no way that dust mites or ragweed randomly popped up near his bed or something, right? That's not what's happening there. So another answer choice here could have been to add omalizumab to get rid of the allergic aspect and take away the IgE, or the other Zumab, which takes away the interleukin 5, but that's not what you're doing here, right? You don't skip steps like that, because adding the corticosteroid may actually take care of that as well by reducing the inflammation that you normally get from allergies, right? So omalizumab or mepolizumab, they're pretty much named very similarly. You won't miss it because of the Zumab aspect. And that's asthma. Asthma is a huge one, so that took up this entire episode. In the next one, we'll go into the quicker stuff. Bronchiectasis is pretty straightforward, not that confusing. We have a bunch of practice questions for all of that, and then COPD, which is also pretty much just as big as asthma. We'll wrap up all of COPD. We'll look at a lot more chest x-rays from the step 1 book, and that'll take care of all your obstructive lung diseases. A bunch of more practice questions to wrap that up, understand different presentations you can get, more workflow shit that you need to know for your questions, how these graphs are going to be used now that we have good understanding of them and we know what all this means, and then we'll be done and we'll move on to restricted lung diseases. So this weekend I'm mainly just also going to be doing CK videos. So step 1, Saturday and Sunday is also just going to be straight up CK sessions, and we're going to try to get through all of this weekend and finish up the restricted lung diseases as well. All right, so yeah, thanks a lot.